Thank you, and good afternoon. I'm Kathleen Ethier, Director of Programming at the National Institute for Healthcare Management Foundation, and on behalf of NIHCM Foundation, welcome to our webinar today. At NIHCM, we've been exploring mental health trends among teens, including the rising rates of mental illness and suicide. Mental illness is increasingly common in young people and may persist throughout their lifetime. In fact, 75% of all lifetime mental illness develops by age 24. Among young people, the most common mental illnesses are anxiety and depression. Nearly 1 in 3 teens aged 13 to 18 has an anxiety disorder, and prevalence of major depression continues to rise, particularly among young people 12 to 17 years old and 18 to 25 years old, compared to those 26 and older. Mental illness is also a risk factor for suicide, which we are seeing increase among young people. While death by suicide rates remain higher for older teens and young adults, we've seen the greatest percent change increase among our youngest age group. From 2000 to 2017, death by suicide increased by 67% among youth ages 10 to 14 and 48% among youth ages 15 to 19. Identifying those at risk and connecting them to resources is key to improving mental health and preventing suicide among young people. Today, we will hear about evidence-based strategies and school-based programs that get teens help when they need it most. We've convened a prestigious panel of experts to share their innovative efforts. Before we hear from them, I want to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM staff who helped to convene this event today, including Kate Ellis, Josh Hamburg, Harper Schwartz, and Kirsten Wade. I also want to thank Trust for America's Health, or TIFA, for their insight and support in planning this webinar. You can find biographical information for all of our speakers, along with today's agenda and copies of slides on our website. We also invite you to live tweet during the webinar today using the hashtag #TeenMentalHealth. I am now pleased to introduce our first speaker, Kathleen Ethier, who is the Director of the Centers for Disease Control and Prevention's Division of Adolescent and School Health in the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention. CDC-DASH works to promote environments where youth can gain fundamental health knowledge and skills, establish healthy behaviors for a lifetime, and connect to health services. Prior to her appointment as Director of DASH, Dr. Ethier served in a variety of capacities across the agency, where she focused on developing strategic direction for agency priorities, best practices for using data for decision-making, and improving program evaluation. We're so grateful she's with us today to provide a federal perspective on adolescent mental health and share how DASH helps schools support students and improve mental health. Dr. Ethier?
Thank you so much for including me in this really very important presentation on this increasingly urgent issue. As mentioned, I'm Kathleen Ethier. I'm the Director of the Division of Adolescent and School Health, or DASH, as you will often hear us referred as. And I'm going to give you a brief overview of the division, talk about some important data that frames why we're all here today, and what schools can do to support mental health among youth, and then some findings from our own work in schools. In the Division of Adolescent and School Health, the vision that guides us is one where all youth have the knowledge, skills, and resources they need, not only during their adolescence, but to help them move into healthy adulthood. As you all know, adolescence is a key time for most health issues, including mental health. Behaviors and experiences start to solidify, setting up the trajectory for the later years. But it's also the last time we have most adolescents together in one place, that is their schools, with the opportunity for wide-scale intervention before they set off into the next phase of their development. So a little bit about how DASH helps. We are currently funded under the Domestic HIV Appropriations line for CDC, and with those funds we do three things. We provide school district support for an approach to improve primary prevention of HIV, other STDs, and teen pregnancy through the prevention of behaviors and experiences, including mental health, that place youth at risk. We do monitoring and evaluation of our district programs, as well as tool development and investigation of emerging issues and solutions. And then we also do school-based surveillance of youth behaviors and experiences through the Youth Risk Behavior Survey, and school-based policies and practices through our profile system. Mental health is included in our surveillance systems, and we use those as well as other sources of data to monitor the state of adolescent mental health. These data tell us that we are moving toward an increasing mental health crisis among youth in this country. This data from the Youth Risk Behavior Survey, our biennial school-based survey of high school students, shows that experience of emotional distress and suicide ideation increased significantly between 2007 and 2017, and that almost a third of high school students in 2017 said that they experienced sadness and hopelessness that they were to the extent that they were unable to do their regular activities for at least 2 weeks in the last year. In addition, SAMHSA's National Survey on Drug Use and Health also shows a significant increase in adolescents reporting major depressive episodes from 2017 to 2018, and the percentage of adolescents in 2018 who had a past year MD with severe impairment was also higher than from 2006 to 2016. When we start to break this down a little further, we see that the increases in emotional distress are driven primarily by female students, among whom more than 40% in 2017 said that they were so distressed that they could not perform regular activities. We also see that sexual minority students, including those who identify as lesbian, gay, or bisexual, those who are unsure of their sexual identity, and those who have had any same-sex partners, bear the brunt of both emotional distress and suicide ideation. And here you're seeing the proportion of sexual minority youth who have ever attempted suicide in the last 12 months. We know that the experience of mental health issues during adolescence has implications during those years as well as into adulthood. We know that mental health issues are more likely in youth who have experienced child abuse and neglect, as well as other adverse childhood experiences, like bullying and other forms of violence. Mental health issues cluster with substance use, suicide risk, as well as sexual risk behaviors that place youth at risk for a variety of poor health outcomes. All of these set the stage for further health issues in adulthood, including violence victimization and perpetration, substance use, and suicide. For example, children who experience physical abuse or neglect early in their lives are at greater risk for being abused by dating partners as teens. Children who have witnessed parental violence are more likely to bully and act violently towards peers and dating partners, attempt suicide, and abuse their children and intimate partners and perpetrate sexual violence later in life. Fortunately, there are a number of factors, such as school connectedness, that increase children's, families, and communities' resilience and reduce the likelihood of multiple forms of violence from occurring. In our YRBS data, we see that significant proportions of youth experience multiple risks. When we look at the intersection of mental health, violence victimization, what we term high-risk substance use, which is a combination of illicit drug use like heroin or cocaine use, injection drug use, and opioid use, and sexual risk behavior, we see that although a third of students don't have any of these risks, more than a third have at least two, and almost a quarter of students experience both violence victimization and mental health issues. Despite this great need among youth, there are significant gaps in treatment. You can see here that among students who experience each of these issues, including substance use disorder and any mental illness, the bulk, as portrayed with the lighter shading in the bars, do not receive treatment. But we know that schools can play a role in both promoting mental health and providing a pathway for treatment for those who need it. In terms of those adolescents who receive mental health services, 3.4 million adolescents receive those services in an education setting, and here you can see the sky blue line in the chart, exceeded only by specialty mental health settings. So we know that schools can be a pathway to service delivery for those with diagnosed mental health needs. But what about the large proportion of youth who either do not yet have a diagnosis or who are not yet experiencing mental health issues? We find it helpful to think about what schools can do, all the way from promoting positive emotional and social and behavioral health supports for all students, referred to as Tier 1 in this pyramid, to more specific supports for students at higher risk, or Tier 2, to the Tier 3 supports for students with identified issues that require more intensive intervention. So I want to focus for a few minutes on that Tier 1 approach to talk about what schools can do for all students. From our work in DASH, we know that schools, in addition to academic learning, have the ability to do three things really well that support students if they have the resources to do them. The first is to provide quality health education that is medically accurate, developmentally appropriate, and culturally relevant and inclusive, and provides the knowledge and skills as a basis for health decisions and experiences. Second, schools can be a gateway for connections to needed services, both in schools and in communities, including mental and behavioral health services. Third, schools provide the daily environmental supports for students that can support them and make them feel safe and connected. And this is really where I want to spend my last few minutes. School connectedness, or the belief that adults and peers in your school care about you, your progress, and your well-being, has positive impacts both in adolescence and well into adulthood on all of the issues we've been discussing today, including violence, substance use, sexual risk, and mental health. A study that we published last summer using data from the National Longitudinal Survey of Adolescent and Adult Health found that school and family connectedness measured in 7th and 12th through 12th grades can lower the likelihood for all of these health risk behaviors and experiences into the late 20s and early 30s, a 20-year impact. Both school and family connectedness were also found to be associated with an increased likelihood of graduating from college. So the impact of school connectedness is wide and deep. And we know how to increase school connectedness. In our work with school districts across the country, we asked them to put a set of activities in place in their middle schools and high schools to improve connectedness. We asked them to provide professional development on classroom management and put policies and practices in place that support youth through classroom management. We asked school districts to implement school-based positive youth development programs or connect students to programs in their community. So the two aspects here are we bring mentoring programs into the schools, and then we also connect students out to do service learning in their communities. We also have established the importance of student-led clubs that support LGBTQ youth. We also know the importance of family engagement, and so have asked our districts to work to improve family connectedness by sharing resources with families about positive parenting practices like monitoring and communication. And what we find is that when middle schools and high schools put these practices in place, we see positive impacts. From 2014 to 2018, when CDC funded districts that implemented school connectedness strategies, we saw declines in negative health behaviors and experiences among students, including reduced sexual risk behavior, reductions in substance use, reductions in violence victimization, and improvements in mental health and reductions in suicide ideation. We also know that this kind of primary prevention work does not need to break the bank. Both that program and our current 5-year program, which implement the same activities, reach about 2 million students a year and cost less than $10 per student. In summary, mental health among adolescents is a critical public health issue. It is becoming increasingly evident from data and from what schools are telling us that youth are experiencing higher levels of emotional distress. And it is going to take more than just public health working on this issue to make an impact. The good news is that primary prevention saves lives and money. We're not talking about standalone curriculum. We're talking about programs, policies, and practices that improve school climate and, in turn, help youth feel more connected in their schools. We know that school connectedness improves student outcomes. We've seen this through our own programs as well as a wide body of research. Schools are key to this work. There is strong evidence that tells us that schools are a place to do effective primary prevention. It is time for us to make sure that this is happening in more schools. And so if you walk away with one thing from this webinar today, please keep in mind that there is real power in schools and their ability to implement primary prevention. Our nation's youth need help, and we have the tools to start providing that. I encourage you all to learn more about how your school district is doing. Our most recent national YRBS data will be released in August. In the meantime, look at your profiles data, see if your district or state collects youth risk behavior and surveillance data, and utilize the tools that we provide on our website to implement strategies that will make schools more supportive spaces. And our contact information is here, and you are welcome to visit our website to find out about any of the resources that we provide. Thank you very much.
Thank you so much, Dr. Ethier, for being with us today and for CDC's leadership supporting school connectedness. As you mentioned, no one stakeholder can address our adolescent mental health crisis, and our remaining panelists will delve into how multi-sector and cross-sector partnerships and collaborations are working to strengthen some of the strategies you mentioned today. We are now joined by John Auerbach, President and CEO of Trust for America's Health, or TIFA. John has held senior public health positions at the CDC and as both Boston and Massachusetts State Health Commissioner. At each level, his work involves efforts to promote health and prevent suicide and other leading causes of death. Under his leadership, TIFA's Pain in the Nation work has drawn critical attention to deaths of despair in America and facilitated dialogue on how to advance evidence-based strategies to promote wellness. We're excited that John is with us today to discuss their latest Pain in the Nation series report on addressing adolescent suicide and substance use. John?
Well, thank you very much. It's a pleasure to join my colleagues today to discuss this important issue. The information I will be presenting is from a recent report that Trust for America's Health released on the topic of adolescent health with the title you see on the slide. It focused on the multi-sector work that is needed to prevent teen substance misuse and suicide. And the full report is available at our website at www.tfah.org under the section on diseases of despair. And at the end of my presentation, I'll highlight the direct link to the report. Trust for America's Health is a nonprofit, nonpartisan organization, and we focus on health policy research and advocacy work. We are also supported by and work in partnership with the Wellbeing Trust, which is a national foundation dedicated to advancing mental, social, and spiritual health of the nation. And together, the two of us have worked on the report that I am reporting on today, as well as a wide variety of other activities. Trust for America's Health is a data-informed organization, and in looking at the most recent data regarding adolescent health, we were pleased to see some good news, so I want to start with that good news. On the chart on the left, hopefully you can see that binge drinking among teens is down. Over the last 2 decades, binge drinking among 12th graders has gone down from about 32% to 14%, with similar drops among 10th and 8th graders. In addition, daily alcohol use by teens is down by 3/4, and past month use among teens is down by 1/2. In another piece of good news, students in 8th, 10th, and 12th grades have experienced a decline in past year illicit drug use from 16% to 9% in 2018. That's the chart you see on the right. These positive signs are encouraging and worth noting because they indicate that we can make a difference in teen health if we invest in evidence-based approaches and apply the resources that are necessary in order to make a difference. And we need that encouragement because, of course, there is also some bad news. Perhaps the most disturbing news, as you've heard already, is that the suicide rates among 12 to 19-year-olds have increased dramatically. In fact, 87% from 2007 to 2017. And that's about 3,000 12 to 19-year-olds who died by suicide in 2017. And while the illicit drug use is down, there have been increases in teen opioid deaths over the last decade that were related to inappropriate use of prescription drugs, as we've seen in other populations. And these numbers may be plateauing or decreasing now, but we really need to keep monitoring them. And a third indication of disturbing recent news concerns vaping. Rates of vaping among adolescents are climbing dramatically. 37% of teens report having used an e-cigarette. And in just 1 year, we saw very startling changes you don't really see very often in behavior. From 2017 to 2018, e-cigarette use by high school students increased by 78%, and it increased by 48% among middle students in the same year. Now, when we look at the various data that relates to substance misuse and suicide rates, as Kathleen indicated, we see that all populations are in fact affected, but some populations are at elevated risk, likely as a result of discriminatory or other challenging conditions in their lives. The chart on the left, for example, shows the rate of suicides among American Indian Alaska Native adolescents. It is the highest rate among all race and ethnic groups in the United States. American Indian Alaska Native teens have a suicide rate that's 60% higher than white teens and 2 times the rate of Black and Latinx teens. And as Kathleen indicated, other populations at elevated risk are the gay, lesbian, and bisexual teen populations. And as she mentioned, these rates are much higher. And the staggering number there is 23% of these teens have reported that they've made a suicide attempt. That's almost 1 in 4 of these teens have tried to kill themselves. These rates are much higher than that of their heterosexual peers. Sexual minority teens have other risks as well. For example, binge drinking is 5 times greater among them compared with heterosexual students. And we pay attention to these differences because it makes sense to concentrate specific efforts and specific resources on the populations at elevated risk. There's no single intervention program or policy that's going to resolve the substance misuse and suicide risks for adolescents. And similarly, there's no single sector or location that can adequately address these issues on its own. That's why that, in addition to the focus on school in today's webinar, we need to consider the roles of other sectors. Schools can do a lot, but they just can't do it alone. Because my colleagues will be focusing more attention on the school-based approaches that are needed, I'll complement that somewhat by highlighting the other sectors that have an important role to play. As this slide says, reducing adolescent substance misuse and suicide and other negative outcomes requires an integrated, multi-sector approach that's grounded in prevention. And in addition to being multi-sector, the approaches needed exist along a spectrum. We need to have policies that address the upstream causes related to major social and economic factors in the lives of the families and teens and adolescents, as well as paying a lot of attention to building resilience among the children and teens that have already faced or will in fact face trauma, as well as the availability of high-quality, accessible clinical care for those who urgently need skilled services. So think about that spectrum, think about the need for multiple sectors approaches. And to focus the attention on what can be done all along that spectrum and with other sectors, I want to highlight the 5 areas of recommendations that we included in the adolescent report. The first one is supporting and nurturing families. It recognizes that families are key. Teens are part of the families and they exist in communities. And since the conditions in the family and the communities affect them, we have to work to improve those conditions and not view teens in an isolated way. That means paying attention to such things as the social and economic issues facing the family. Do they need safe and affordable housing, a livable income, enough food on the table? Such programs as the Earned Income Tax Credit and SNAP program can help. Without a stable roof over their head and enough to eat, teens experience trauma. They also need access to comprehensive health care services for all members of the family, not just teens, but certainly including teens. And such services need to include benefits for substance misuse and for mental health. It matters for the parents of the teens because if the parents have untreated behavioral health, they can't provide the parental support that's needed. Families also need counseling and training about parenting. Raising children and teens is stressful and difficult, and families need to be involved and supported. Many schools are recognizing the needs of their students, and as they screen them and identify these needs, they need to know that there are places for such referrals in other sectors that can assist the families. The second recommendation area we make involves promoting positive pathways to educational and life success. The school climate matters a great deal, and we've heard and will also hear more about important programs that work in schools, like DASH. We need to expand these programs to ensure that students feel safe and supported in schools and don't have to worry about violence and bullying. And outside of schools, we need changes in other sectors, many of which are also beginning to occur. For example, we need juvenile justice reform to focus more on prevention and on alternatives to punishment. There are many examples of such evidence-based efforts that keep teens from getting onto the track that will lead to incarceration. Finally, in terms of this point, I want to emphasize that involving teens themselves in authentically identifying the problems and meaningfully solving them is also likely to make the outcomes more successful, according to a growing body of evidence. The third area of recommendation involves creating community environments that promote mental health and physical health. And there's much that we can do to create other community environments for teens that are healthier. And here I want to focus on some of the broader issues that are important to pay attention to. We need to combat systemic racism, factors that close off economic and educational opportunities, for example, to black families and their children. Similarly, we need to combat homophobia and transphobia at the community level as well as in schools. Discrimination and violent practices at the community level elevate the risk of suicide and substance use among these teens. We also need anti-poverty programs to help residents get livable wages and secure employment, as I mentioned. And finally, another example of the importance of environment is creating anti-violent efforts at the community level to reduce homicides, domestic and sexual assault, with both a primary prevention approach and a rapid response teen support when violence occurs. I worked with a program in the Boston Public Health Commission that still exists that focused on offering immediate interventions when there was a homicide or other violence in the community, both for teens as well as other members of the community, to try to prevent a continuation of the violence or an exacerbation of the trauma that resulted. And excellent work is also being done by Dr. John Rich at Drexel University in terms of considering effective ways to address violence and prevent it. From TIFA's perspective, one way to tackle these really difficult issues is by getting the public sector involved in a significant way. And Trust for America's Health, for example, has proposed a new line item at CDC that would give it, as well as state and local health departments, the resources they need to address the social determinants of health in order to engage on the policies that I've just mentioned. A fourth area to focus on should be coming up soon, is building infrastructure to align work across sectors. Now here I would give you the example that in our planning work that preceded the writing of the recent report, we convened members of multiple sectors, from juvenile justice, healthcare, educational, public health, and the like. And we found that leaders in these sectors were engaged in interventions to help those teens at risk. But when we talked about who the teens were that each of those sectors were working with, we realized that each one of the sectors was working very often with the same teens and their families. But most often this work was independent of each other, and the sectors were unaware of what the others were doing, rather than coordinated. As such, resources were wasted and opportunities lost, and that's why we recommend efforts to bring the various sectors to the same table for coordinated multi-sector planning. Now, to achieve this, we need funding that incentivizes such collaborations. We need efforts to eliminate the red tape that makes collaboration difficult. We need to develop opportunities to braid and blend funding streams so that they are easier to work together. And we need to build multi-sector coalitions that are at the local community level as well as at the state and the federal levels. And then our fifth and final area is increasing funding for prevention. There's just no getting around the fact that we need more resources to address these issues, and that's certainly true in education, but it's also true in other sectors. Such funding includes evidence-based proven efforts like increased funding for DASH, increased investments in the Garrett Lee Smith Suicide Prevention Program, in CDC's Injury Center, in drug-free communities, and in substance abuse prevention and treatment block grants. There must be resources also all along the spectrum that I mentioned earlier, not just resources at the time of crisis, which are clearly important, but also for primary prevention, for changing the conditions that contribute to mental health and substance abuse at the community and family level, and for screening and for post-treatment long-term support for recovery. Now, there's some resources that are helpful for those who are interested in these admittedly difficult challenges. One of those important resources just became available a few weeks ago. It's called Healing the Nation, Advanced Mental Health and Addiction Policy. It's a framework for action. It was developed by the Wellbeing Trust, and it provides meaningful solutions that can help advance mental health policy. It focuses on multiple entry points for policy: health systems, judicial systems, educational systems, workplace and employment, and the whole community. So please go to the website on this screen for more information on Healing the Nation. It will also provide you with examples of legislation that's being considered at the federal level to strengthen behavioral health in the schools and in other sectors. Finally, I want you to be aware of a group that Trust for America's Health is a member of called the Wellbeing Working Group. Those of you who are on the phone who are interested in knowing more about this or participating in this, please contact the person that's listed on the slide, Jonna Cunningham at jcunningham@tifa.org. The Wellbeing Working Group is a collaborative that focuses on primary prevention and health equity strategies to address substance misuse, suicide, and mental and emotional distress, particularly at the federal level. It's intentionally composed of representatives of the multiple sectors I was mentioning, And together, the group supports population-level policy strategies to prevent the initial onset of mental health and addiction challenges by improving the social, physical, and economic conditions in communities. We host monthly meetings that you can join if you're interested, and we have a bi-monthly newsletter. And this group is also a part of the Wellbeing Trust's Wellbeing Alliance, which has a number of collaboratives. This collaborative, as you can tell, focuses on the issues of mental health and substance use. So with that, again, let me say thank you, and I look forward to hearing the presentations from the others on the panel.
Thank you so much, John, for your leadership and for TIFA's leadership on sharing all this great information. I know your reports are just a wealth of strategies, and we hope the conversation today facilitates continued investment and commitment to these evidence-based strategies to promote positive mental health. Our next speaker, Alexandra Mays, is the Senior National Program Director at Healthy Schools Campaign. The Healthy Schools Campaign strives to ensure all children have access to healthy school environments where they can learn and thrive. Ms. Mays leads the campaign's work to increase access to school health services through Medicaid reimbursement and works with states and school districts across the country to expand their school Medicaid programs. We're so fortunate to have Ms. Mays with us today to share findings from a learning collaborative working to increase access to mental health services in schools and promote safe and supportive school environments. Alex?
Great. Thank you so much, and thank you to NIHCM for hosting today's webinar on this incredibly important topic. So again, my name is Alex Mays. I'm the Senior National Program Director for Healthy Schools Campaign, and we're a Chicago-based nonprofit, and all of our work really sits at this intersection of health and education, and we work to ensure that all students and staff have the opportunity to learn and work in a healthy school environment. And so what I really want to do today is share lessons that we've learned over the last 4 or so years from our work that we have actually done in partnership with Trust for America's Health. It's wonderful to follow John. And that work is really centered around how we can support states in expanding access to school health services and safe and supportive school environments. And a core component of this work has been looking at how we can expand access to school mental health services. So I want to share some of the lessons learned from that work and lift up some of the great state work that we're seeing take place to move these efforts forward. So the effort that I specifically want to share more about is called the Healthy Students Promising Futures Learning Collaborative. And this was an effort that was launched actually in the summer of 2016 by the U.S. Departments of Health and Human Services and Department of Education. And Healthy Schools Campaign and Trust for America's Health have since taken over leadership and now co-convene the effort. And the Learning Collaborative really focuses around this goal of how we can provide states with opportunities for technical assistance and training and peer-to-peer learning around how they can increase access to Medicaid services in schools and promote safe and supportive school environments. We currently have 15 states that are participating in the Learning Collaborative, and what it means for those states to participate is that they've all formed state teams that include representatives from their state Medicaid agencies, their state education agencies, and then at least 2 local school districts. And many include a number of other partners on these teams, from state public health to advocacy organizations to state stakeholder associations such as State Association of School Nurses and the school-based health centers. But really core to this work is looking at how we can bring together these cross-sector, cross-level partners to move forward this work around expanding access to school health services and safe and supportive school environments. We also have a whole host of national partner organizations that are supporting the work to really also provide technical assistance to those states. And so while the focus of the Learning Collaborative is a little bigger than just mental health, what we have seen over the last couple years has just been a tremendous amount of increased attention around the need to support school mental health services and safe and supportive school environments, and really an eagerness from states and school districts across the country to identify evidence-based interventions and strategies that they can be implementing to advance this work and meet the needs of students. And I think there are a number of factors that really are driving this increased attention and this demand that we're seeing from states, including a lot of what has been referenced by previous speakers of just this increased recognition of this critical relationship between health and learning, but also an increased understanding of unmet student mental health needs, and the unfortunate reality that so many students are coming into school with unmet mental health needs that impact both their ability to learn and then also their long-term health and wellness. There's also a number of key policy opportunities that really present a chance for states and school districts to move forward this work around supporting mental health and wellness within schools. There's a very specific opportunity within Medicaid, which I'll go into a little more detail about in a moment, but a chance to draw down additional federal resources to advance this work. And then a key shift also has been on the education side. And in 2015, a new education law was passed called the Every Student Succeeds Act, which replaced what we all knew as No Child Left Behind. And really, we see it as representing a paradigm shift in terms of recognizing the importance of supporting health and wellness and the whole child, and really creating a tremendous amount of flexibility for states and school districts in how they go about doing that, including some very specific funding opportunities to support mental health and wellness within school environments. And then in addition, it's been so eloquently framed by previous speakers, the rise in terms of the opioid epidemics and suicide epidemics, as well as very real concerns about school safety, have really been driving a lot of attention around the need to support school mental health services. And so just to level set, when we talk about mental health services in schools, we find that many people come in with kind of a preconceived notion of what that could mean. And really what we see is that by no means is this a one-size-fits-all model, that we often see districts and communities bringing together a variety of models to be delivering mental health services within schools, and in turn, leveraging a number of different funding mechanisms to support that work. So from more traditional models like school-employed providers such as school psychologists and school social workers and school counselors, to mobile vans where you have partnerships, with hospitals and other providers that are actually bringing in mobile vans to do delivery of services, to telehealth, which is where we're actually seeing a lot of momentum building as communities are faced with lack of access to mental health providers and increasingly relying on programs that are driven by telehealth to enable communities to be connecting with providers remotely to do this work. And then another very common model that we see is really partnerships with Medicaid providers and with providers within communities. And so that could be partnerships with school-based health centers that are located on site with schools or nearby and linked to the school and run by federally qualified health centers. Or we increasingly see partnerships with managed care organizations to create unique structures to really think about how we can be funding this work within schools. Partnerships with children's hospitals and really looking at the role that they can play to be supporting delivery of mental health services and programs within schools. But I think across the board, what we really have seen is this tremendous amount of cross-sector collaboration around this work, and not only this recognition from education of the critical importance of supporting mental health and wellness within schools, but also on the healthcare and public health side of the tremendous value that there is in terms of partnering with schools to really meet the mental health and wellness needs of students. And so I wanted to take some time to specifically dig into some of the opportunities and some bright spots as well that we have seen emerge from the Healthy Students Promising Futures Learning Collaborative. And the first one that I want to dig into is specifically around leveraging Medicaid funding to support the delivery of mental health services within schools. which is really an exciting opportunity for states and school districts to be looking at as a mechanism to draw down funding to really support the expansion of mental health services within schools. Medicaid has had a long-standing role of funding health services within schools. But that setup has been limited to a very specific set of services. And specifically, historically, Medicaid has only reimbursed for services that are explicitly included in students' individualized education program or special education services. So those tend to be more services like speech therapy and occupational therapy and physical therapy, and less of your mental health services that we know are being delivered within schools. And so while there has been this long-standing history of Medicaid reimbursing school districts for services that are delivered, it has really been for a limited scope of services. Only about 14% of students across the country have individualized education programs. But fortunately, almost exactly 5 years ago, Centers for Medicare and Medicaid Services actually issued a state Medicaid director's letter, which changed this longstanding policy and explicitly said that Medicaid reimbursement to schools is no longer restricted to those services that are included in a student's individualized education program, which essentially means that now states can make the decision to allow school districts to seek reimbursement for any Medicaid-eligible service delivered to any Medicaid-enrolled kid, which is a tremendous opportunity for supporting the delivery of school mental health services within schools. So any Medicaid-eligible mental health service that is being delivered within the school district, traditionally there have been some very stringent limitations around that, and there's now an opportunity to seek Medicaid reimbursement for those services. The one key point is that states need to make the decision to move forward with this change, and the majority of states need to submit a formal request to Centers for Medicare and Medicaid Services via a state plan amendment change to implement this change. So the state Medicaid plans are intended to be living documents. State plan amendments are submitted regularly. It's by no means an insurmountable barrier, but it is a step that states have to take and means that in most states that decision needs to be made, and this is not an opportunity that is automatically available to districts. So just to highlight where we are since this policy has been changed, there's been 10 states that have moved forward with this opportunity, and then those are in darker green, and then 4 states that have requests pending with Centers for Medicare and Medicaid Services. The majority of these have moved forward with this change within the last year. Again, this increased recognition of the role that schools can play in terms of meeting student mental health needs has been driving a tremendous amount of momentum around states leveraging this opportunity. Michigan is a really nice example of a state that has done this. They passed legislation in 2018 that allocated $31 million in funding to hire mental health providers for the general student population, so students without individualized education programs. And then as a part of that legislation, they required the state to expand their school Medicaid program and leverage this opportunity to enable school districts to seek Medicaid reimbursement for an expanded range of services. And they also really looked at who was delivering mental health services within schools and saw that it was school psychologists and school social workers and school counselors, behavior analysts, and a range of other providers, and determined that those providers couldn't actually bill Medicaid for those services, and so they went ahead and added those providers as well as a part of their change. So we're really excited to see how the expansion within Medicaid unfolds. I also just wanted to take a moment to highlight a couple other states that are in our learning collaborative that I think just are doing a really tremendous job in terms of thinking about how to support the mental health and wellness of students, and specifically with an eye towards delivering mental health services. Colorado is a fantastic example that we point to frequently. This aligns really well with Dr. Ethier's slide of the multi-tiered systems of support. But Colorado is really looking at how they can support a range of mental health services and mental health programs with an eye towards serving all students. And they're also doing that really with an eye towards how they can support districts and leveraging a range of service delivery models. So looking at how they can deliver services through those school-employed providers, how they can partner with school-based health centers, how they can partner with community providers to bring in therapists to the school districts where districts aren't able to employ them. So it's just a really tremendous model with a lot of fantastic resources that are available through the state to support this work. They're also doing a really great job of braiding together a number of different funding sources to support this work. And I think that is something that we see across the board, is that there often is not one pot of money necessarily to support this work at the state level and district level. And so we see some really innovative work going on to braid and blend funding streams to do this work. So Colorado is leveraging, they have SAMHSA Project Aware funding, they're leveraging Medicaid funding, and they've submitted a request to expand their program. They're leveraging marijuana tax funding to do this work, as well as a number of other federal and state sources of funding. California also has a really fantastic model that is very much framed around supporting trauma-informed schools and bringing together a lot of key partners to do this work. And so they have a statewide social and emotional learning team that brings together a lot of different sectors to advance this work, as well as an interagency team for children and youth that is strongly focused around supporting trauma-informed schools across the state. And they also are leveraging a number of different funding streams to do this work. And then finally, I just wanted to point to South Carolina, which is just a really fantastic model of a statewide school-based telehealth program, which again is a modality of delivering care that we're increasingly seeing used by communities and states. They have one of the fastest growing networks across the, in the country, and it's currently serving 80 schools across the state. And it delivers a range of services from acute illness care to chronic care management, but then mental health is increasingly becoming a focus of that work. Specifically right now, focused around ADHD management and cognitive behavioral therapy via telehealth, but I know they're also looking at expanding to additional mental health services. And that program is actually run by the Medical University of South Carolina, but then they have close partnerships with their state education agency and state Medicaid agency, as well as advocacy groups and districts across the state. So I just wanted to point to one additional resource that I know States in Our Learning Collaborative, I think, have found incredibly helpful, and for folks who are really interested in getting into some more of the nuts and bolts around funding mechanisms to support this work and best practices and evidence-based interventions. Last summer, SAMHSA and CMS released an informational bulletin, which didn't include any new information or decisions, but really does an incredible job of summarizing best practices and more or less creating a menu of options of how this work can be funded. So it covers some of the models that I've discussed today and speaks to the role that school-employed providers and telehealth and partnerships can play in supporting this work, and then also speaks to a number of different funding mechanisms which are listed here. So I just wanted to call attention to that as a very helpful resource we found. I think, you know, a very clear message from those agencies of the role that schools can play in terms of supporting mental health and substance misuse, and then also providing some very concrete steps to support this work. So just to conclude, I wanted to review some of the key lessons that we've learned from this work in terms of working with the 15 states in our learning collaborative. I think a lot of these themes have been emphasized throughout the presentations, but above all, just the value of cross-sector collaboration in terms of moving this work forward and bringing those partners together early. So often in this work, we'll see initiatives that are driven just by education or just by Medicaid or just by other partners. And I think the ones that are most powerful, such as the work happening in Colorado and in California, and even the telehealth example in South Carolina, have really been grounded in the fact that they've brought together a range of partners very early on and looked at all the parties that can support this work and would potentially be impacted by it. Another key lesson learned is just how critical it is to establish common vocabulary between different agencies and partners when you're doing this work. We often find that education and health and public health and others, end up using very different words when they talk about mental health and wellness, particularly as it applies to schools. So, whether it's in your state, if the schools are talking about this work in terms of conditions for learning or safe and supportive school environments or trauma-informed schools, there's just tremendous value for any sector that's looking at establishing these partnerships and looking at where the strategic priorities are for those partners and thinking about how you can really message this work in terms of how it supports that work. And that certainly goes for also, aligning metrics where different sectors can be supporting one another in terms of advancing key metrics that can support this work. And then finally, just, certainly the power of learning from other states and looking at how we can adapt lessons from other states and communities to advance this work, we've just found to be tremendous in terms of building momentum and really recognizing that there's no one-size-fits-all solution, but that there can be a lot learned from looking at how other communities have really dug in and addressed these incredibly challenging issues and leveraging those lessons learned to advance work within your own state or community. So I will wrap up there. My contact information as well as links to our Learning Collaborative website is available there and would welcome any questions, or if folks are interested in learning more or connecting about the Learning Collaborative, would be happy to do that. Thank you.
Thanks so much, Alex, for sharing those really helpful lessons learned and best practices. Our final presentation today will feature a partnership to expand mental health services in Michigan schools. Blue Cross Blue Shield of Michigan Foundation is committed to improving the health of all Michigan residents, and they have been a leader in supporting innovative solutions to improve teen mental health. By partnering with the TRAILS program, they have worked to improve youth access to evidence-based mental health services by training school mental health professionals in effective practices such as cognitive behavioral therapy and mindfulness. We'll hear first from Audrey Harvey at Blue Cross Blue Shield of Michigan Foundation. Audrey joined Blue Cross of Michigan in 1991 and has served in a variety of roles before becoming the foundation's executive director and CEO. In her current role, she oversees the foundation's portfolio of grants to Michigan-based researchers and nonprofit organizations, and she's very passionate about improving the lives of Michigan residents, and we'll hear more about that shortly. We will also hear from Elizabeth Koschmann, who is a faculty member at the University of Michigan Department of Psychiatry and the director of the TRAILS program. In addition to spearheading the original TRAILS pilot project, Dr. Koschmann has worked extensively as a trainer and consultant for a variety of academic and community-based audiences. We're pleased to have both of them here with us today. I'm going to turn it over to them. Audrey?
Good afternoon, and thank you for including the Foundation and the TRAILS program in this wonderful webinar today. As you said, I'm Audrey Harvey, the Executive Director and CEO of the Foundation, and I am pleased to say, as you reiterated, we're a foundation that's completely endowed, and having never received funds from Blue Cross, maintain an endowment of about $60 million, which means we give grants every year for about $2 to $3 million with a focus on the entire state of Michigan in all 83 counties. We do split up our work between those research projects that are often conducted by universities and professors, hospitals, and then those that are conducted by the community that tend to be innovative solutions to the problems that they're seeing where they are located. On slide 3, you'll see that we've done a great deal just in the past 2 years of working on issues that impact the health of teens and their families. And I'm very pleased to say that, as John indicated, the work that you'll see here has focused on 3 of the areas that he pointed out. You'll see that there are projects that would support and nurture families, those that would promote positive pathways to educational life and success, and then those that create community environments that promote mental health and physical health. And we've worked to partner with others to increase the funding for this prevention. I would say if there's anyone that has interest in any of those projects, my information will be included, to please send us a note. We are very happy to share those projects as well as those project directors. But the one that we want to focus on today is the one with University of Michigan and the Trails Project. The Trails Project is a very powerful collaborative that is a public-private collaborative that was really put together by Andrea Cole, the executive director of the Ethel and James Flynn Foundation. She pulled together several foundations, both the Blue Cross Foundation, the Michigan Health Endowment, Metro Health Foundation, the Children's Foundation, the Jewish Fund, DMC Foundation, and the Community Foundation for Southeast Michigan, and more importantly, much to what Alex talked about just recently, also the project receives funding from the Centers for Medicaid and Medicare Services, as well as support from the Michigan Health and Human Services Department. So this is one of the 3 collaboratives that are public-private partnerships that the Foundation's involved with, and is very powerful, because what this program will do is bring resources to each of the Detroit Public School Community District schools, 110 of them, and will reach about 50,000 students. But what I'd like to do at this point is simply turn it over to allow you to get to the meat and potatoes of our presentation, and turn it to Dr. Elizabeth Koschmann.
Hi, thank you so much for having me here and to hear those comments, Audrey, about our partnership with you. We're very grateful for your support, and I'm really honored to be a part of this panel today. So I'd like to just speak very briefly about the Trails program. We are, as Audrey mentioned, a pretty unique university-community collaboration. And our goal at Trails is to improve youth access to multi-tiered evidence-based mental health support services. And I feel that the prior panelists today, especially Dr. Ethier and Ms. Mays, really set a perfect platform for me to talk very briefly about the Trails model. Right now, we're active in approximately 350 schools across the majority of Michigan's 83 counties. And certainly what I would say is that, I'm having a hard time with my slides. There we go. What I would say is that the comments that you've heard already today about the critical role of cross-sector partnerships and engaging local communities in our work is absolutely true. And I usually have a slide up to acknowledge all of the support we get, mostly to express our gratitude. But in this context, I also want to highlight the diversity of partnerships that we have here, and to comment that the role of all of these local foundations and supporters is certainly not just to offer that financial support that, of course, is so critical, but also to help build our community connections. And that is going to be extremely apparent as I go on to talk about our work in Detroit and Detroit Public Schools Community District in particular. Just waiting for that slide. So I don't have to spend a lot of time, I think, setting up the problem that Trails is really focused on responding to. The prior presentations this morning really highlighted this tripartite problem, that we have high rates of mental illness in school-aged youth, difficulties with treatment access due to, of course, a multitude of barriers. And the result is that we have a situation in which our public schools are housing those students and providing the vast majority of mental health services that those students receive. And I was really interested to hear Alex speaking about the role of those school-employed partners, those school social workers, counselors, psychologists, and how many of them really are providing that mental health service. and yet we know that staff and faculty in those positions often really struggle to access ongoing professional development, resources, or the supports that they need to adopt or sustain evidence-based practice delivery with good fidelity. And so at TRAILS, we have tried to use the best evidence from the literature to inform our model for resolving this gap between a school that's perfectly positioned to reach many students and certainly is providing a vast majority of that mental health support to their student population, but often lacks access to the training, resources, and supports that they need to deliver that care effectively. So as you heard in many of those other presentations today, there's a lot of lessons that have been learned in terms of what makes solutions to that research to practice gap viable. And I want to just pause and highlight a few of those that have really informed development of the TRAILS model. In particular, I want to highlight what one of those on the screen is this idea that when we're pushing a model to improve the quality of mental health care service delivery in schools, we really wanted to focus on streamlined interventions and generalizable interventions so that those school social workers and counselors that are serving students are able to utilize skills that we push out to their communities with a wide audience of students. We also have learned from other partnerships and research in the field of implementation science the critical role of engaging those multiple stakeholders across sectors, and particularly in including school leadership. So you're going to hear in my next few slides and comments how we really worked in the Detroit community to build a strong coalition, not only with our community partners, bridging community mental health and local providers, but also starting at the outset with a partnership with the leadership at Detroit Public Schools Community District. And then the last point that I want to highlight here is that we really wanted to build a model that would be appropriate for replication, that we wanted to design a model that could be sustained long-term by existing and established funding sources. And so as you're going to hear my comments, you're going to be able to note ways in which we were trying to stay clear of the risk of building a program that had to rely on grant funding that could be only delivered in 1-year or 2-year increments, but really we wanted to build a model that could take advantage of that ESSA program, of Medicaid, CHIP, public and block grants, title funds, and certainly here in Michigan, we're very interested in the fairly new model of allowing schools to use that Medicaid funding to bill for some of the services that we're supporting schools to deliver. So I'm going to go ahead and introduce the program now. TRAILS is an acronym that stands for Transforming Research into Action to Improve the Lives of Students. And the program really is built on 3 pillars. We provide didactic instruction for those school staff that are providing the majority of that mental health support in the building. We also have an extensive library of online clinical resources that support treatment and care delivery in the school setting. But what makes TRAILS especially unique is that we don't just stop with providing professional development and online resources, but we actually provide extensive post-training implementation support. And that's the coaching that you see up on the screen. And we found that without offering that follow-up coaching support, it's really difficult for schools to sustain their work long-term with students. You've already seen several models earlier in other comments today showcasing this 3-tiered approach. And we also felt it was really critical to align with these established models. And what I'm going to do in my next few comments is I'm going to highlight just one example of a program that TRAILS supports schools to deliver at each of those 3 tiers. So this slide looks like it's not showing perfectly up on the screen today. What I did want to just pause on for a moment was the idea that in order to engage with our school partners and our community supporters, we found it was really critical to have a logic model. So if the graphics were a little bit more seamless today, you would be able to see our logic model. But one thing I can just highlight here is that on the left, what you would see would be those inputs and early activities were really focused on building the support and also collecting data to identify what was critical at the community level so that we could ensure that any outcomes that we were working towards were aligned with district priorities and goals. So now I'm going to go on and just talk briefly about our work in Detroit in particular as a spotlight of one of our many projects. As I said, Trails is engaged already with the majority of counties in Michigan, but as Detroit Public Schools Community District is the largest district in the state with over 100 schools and 50,000 students, we consider this one of our largest and most critical initiatives currently. In terms of that broad stakeholder support, you can see up on the screen there are many sectors that are involved in our work. Certainly here at the University of Michigan, our medical school, Department of Psychiatry, and Comprehensive Depression Center. We also partner closely with the School of Public Policy, who supports a lot of our evaluation work and data collection. Of course, the district itself, as well as you heard Audrey mention in her opening slide that there is a strong consortium of Michigan funders that have played a critical role, as well as state departments. And in Wayne County, very importantly, we partner with Detroit-Wayne Integrated Health Network, which contracts with a large number of the mental health agencies in Wayne County that provide community-based mental health care. Here's just a quick timeline of some of our primary goals in our work with Detroit Public Schools Community District. And as you can see, it begins with the really critical phase of a needs assessment, that we really wanted to take the time up front to collect information from the district about what they hope to accomplish through the partnership. In year 2, where we are currently, we wanted to pilot some of the programs that came as recommendations from that needs assessment work. And then in years 3 and 4, we wanted to more fully implement programming district-wide and analyze the data that we collect to inform our understanding of program success. So it's beyond the scope of my comments today to talk in depth about the surveys that were administered across the district in Detroit and the findings that came out of that surveys. But I will just highlight, because this phase was so essential, we were able to collect almost 20,000 unique surveys from the district, spanning populations of students, staff, and families, as well as local community mental health providers and agencies, foundations, and even reaching into the security and police officers and other professional groups that are affiliated with the school district. And we're really looking to this data to inform not only the work that we do, but also to provide a clear baseline to help us evaluate that long-term impact. So returning now to that 3-tiered model, I'm going to just provide one example at each of these tiers of the kinds of supports that Trails helps schools to implement. So at Tier 1, Trails has recently developed a social-emotional learning curriculum for the classroom, and that is strongly aligned with the CASEL recommended 5 competency areas for social-emotional learning. Our curriculum is also very strongly grounded in the evidence-based theoretical framework of cognitive behavioral therapy. And as we built the model, we were really focused on ensuring that the model would be for teachers who would be delivering our curriculum low cost, low time in terms of time out from academic instruction, and low burden. So this curriculum will be piloted this fall across Detroit Public Schools and will be implemented district-wide in the coming couple of years. At Tier 2, we wanted to align a program with that social-emotional learning curriculum, but step up that level of care for kids with a higher level of need. And this is where I want to return for a moment to those 3 pillars that I mentioned at the outset: training, resources, and coaching as an implementation support. The way the Trails model works is that we provide
professional development training for school mental health professionals in core elements of CBT. We also provide, as I mentioned, that library of free resources at our website, trails2wellness.org, which I'll share at the end of my comments. And those resources support all of the clinical skills and work that those school partners want to offer with their students. But what makes Trails unique is this coaching component. Coaching is provided directly at the school in person, and what we do is we establish Trails coaches who actually come out to the school and sit shoulder to shoulder with those school professionals, and they co-deliver student skills groups to real students who are impacted by symptoms of depression, anxiety, or post-traumatic stress, among other mental health concerns. By delivering coaching in person, we're able to help those school professionals really practice the skills that we teach, and they also receive feedback and support and help with planning for upcoming work that they might have with students. Now, in order to scale statewide, we had to develop a really robust coach network. And what you can see in the map on the left is that we currently have more than 100 coaches spread across the state of Michigan. And those coaches are primarily sourced from community mental health. We engage with community mental health agencies, and then their providers receive clinical training from us, as well as training in how to serve in their local communities as coaches. They also receive specific coaching resources and consultation from a supervisor here at Trails. One thing I want to mention was in terms of developing this coach network to be able to scale our program and to partner with so many communities across Michigan, it was not a primary goal at Trails to improve the quality of mental health care provided in the CMH offices, but of course we were collecting data from those agencies as we were bringing coaches on to serve in their local communities. And what that data was showcasing for us was that, in fact, along the path to developing a coach network, we also were improving the quality of care that was offered at community mental health offices, in that the providers who participated to become coaches ultimately reported higher frequency use of evidence-based practices, particularly CBT, use of more widespread components of CBT, so using those higher level or more complex treatment skills, generalization of those treatment skills to the majority of their to their caseload cases. And when we looked at data from those cases that our Trails coaches were treating in their own clinical settings, we saw significant improvements in symptoms of depression and anxiety, and increased use among those clients of adaptive and effective coping skills. So moving back to our pyramid here, I'm just going to touch on one more program at Tier 3, and that is thinking about how to support schools to help their students at high risk of suicide. We know this is an area that schools are increasingly asking for support with, and there are many ways in which we could partner with schools. Certainly gatekeeper training is one of the most highly requested ways to partner. But in particular, I just want to highlight a tool that we developed locally in Washtenaw County that is now expanding to Detroit and Wayne County. And this is a tool to help improve care coordination across multiple settings. We had a lot of schools tell us that they were concerned about students at risk of suicide, and they would refer those students to a higher level of care, and then they wouldn't be able to know what happened to those students after those referrals were made. So what you see on the left side of the screen is a cover sheet of a packet that includes a standardized suicide risk screener, as well as scoring guidelines and triage recommendations. But on the right side of the screen, what you see is our Psychiatric Emergency Services Referral and Communication tool. And this tool has the top half, which is information that the schools provide when the referral is made from the school to an external higher level of care. The bottom half of the screen is recommendations and summaries that come from that external care provider. Usually this is the emergency department or a crisis team at the county level, and that information comes back to the school. And what we have found in our work so far locally is that not only has this tool improved care coordination, but it's also really increased the level of appropriateness of students who are appearing at the emergency department for a psychiatric evaluation. So those kids are more likely to be admitted through the ED rather than to be sent home without a follow-up admission. Lots of ways in which we are evaluating our work, certainly across the district, students, and families. And as we collect increasing data documenting the benefit of the TRAILS program, we have decided to move towards a model of readiness assessment so that as requests to bring the TRAILS program broadly across Michigan and more recently nationally, we are able to assist schools with evaluating their readiness to bring a program like TRAILS along. So I have a slide here for questions, but I think we're going to turn it back to the larger group to field those questions for all of the panelists today. Thank you.
Thank you so much, Audrey and Elizabeth, for sharing the TRAILS program and how this approach is supporting students and improving care coordination. We're looking forward to watching as the program continues to grow and expand. I know our audience is eager to continue to learn from all of you, so I'll ask our speakers to come off of mute, and we will go through as many questions as we can. If we don't get to your question, we will share questions with the speakers after the webinar. I wanted to start with a question for Elizabeth. Could you talk a little bit more about how you engage with the coaches? Are they volunteering? Is their home organization paying for the services? Are they receiving a stipend? And then could you also share like what program documents people might be able to find on your website?
Sure, that's a great question. So no, they certainly do not volunteer. What I would say is that our agency partners often are so eager to get high-quality training in CBT and mindfulness that we are usually very successful in offering opportunities for agencies to send their staff to our professional development trainings. We offer free CEUs and materials and support, follow-up support to those clinicians that generally we have no trouble filling to capacity our trainings. And in terms of providing the coaching, it's a pretty minimal amount of time. Schools typically only engage for 1 or 2 semesters of coaching before they really don't feel that they need it any longer. They feel that their school staff is able to sustain the model independently without the coaching. And during coaching, it's a maximum of about 1 to 1.5 hours per week. And the agencies have reported that the improvement in quality of professional relationships with the schools is valuable enough to them that it is worth that small amount of time to be able to partner with those districts locally. I would be happy to talk about our website. I would encourage you to go to our website and look at the resources and materials section instead so I don't take up too much time of our question period here.
Great, thank you. John, you had mentioned the important role of families earlier, and we had a question come in for you or for any of the speakers about how schools can best communicate and teach student or teen mental health needs and practices to parents and guardians.
Well, I can start, but I think my panelists will probably also have thoughts. In my experience as a local health official, we ran many different school-based health centers and did other interventions in schools. And what we found was it really took a concerted effort. It really meant regularly communicating with parents, creating opportunities at times and under circumstances that were convenient for them. Many of them work, for example, so that they could feel like it was possible to come in and have a conversation. raise the issues that were important to them, as well as what the school was offering in terms of different potential programs. So I think it really is, the core of it is establishing a mechanism for meaningful communication with parents whose lives may make it more complicated for them to be available during regular school hours. But it can be done, and it is being done in many settings.
Did anyone else want to weigh in, Alex or Elizabeth, about engaging with families?
This is Kathleen. We've had some success in engaging parents and families more thoroughly in the school environment through parent advisory groups in some of the schools that we've funded, school districts that we've funded, around curriculum choices, and then also in distributing information about positive parenting practices to parents. And I think John's right. A lot depends on. There's different modalities, and I think you have to provide enough information in enough different ways because parents are busy, because most parents work during the day. Expecting them to be able to show up at their kids' school is a lot to expect. So when we've done that, we've just made sure that we do things, that districts do things at different times of day, that and then providing information in different modalities and in different platforms in order to make sure you're reaching kind of the most parents that you can.
Great, thank you. We had a few questions come in about the need for sort of peer-to-peer training for teens and helping them how to react or handle a situation with their friends. Is that something that the group could speak to? Are there any best practices or programs that you could share with the audience?
This is Elizabeth Koschmann. I can comment on that briefly. Certainly that was a priority of Detroit Public Schools Community District. They were very clear at the outset that that was something they really wanted. And the University of Michigan Depression Center has a peer support program called Peer-to-Peer with the number 2 in the middle that was recently awarded the American Psychological Association's Gold Medal Award. It's an evidence-based model that looks at peers as really critical informants for their classmates about recognizing mental illness and just sort of finding ways to support students to engage in help seeking and overcome some of those barriers. So in our work, that's one of our Tier 1 programs that we hope to implement district-wide.
Great, thank you. We spoke a little bit earlier, and you all shared some data about the LGBTQ+ population. We know that there's drastic differences among transgender youth in terms of suicide attempts. Could any of the panelists share any work that's being done to address the individualized needs of trans youth? And I'll just start by sharing, NIHCM did a webinar last year. There's a presentation from the Trevor Project, and they have a lot of great resources, but would be curious, open it up to the rest of the panel as well.
This is Kathleen. We one of the required activities for all of our funded districts is that the schools put gay-straight alliances or GSAs or gender and sexuality alliances in all of their middle schools and high schools, and we've had surprising success in districts being able to do that work, even some of the more conservative districts that we work in. And I think that putting those kinds of supports in place for LGBTQ+ kids is incredibly important. And what the data shows is that it's not only important for those youth, but for all youth, that it just changes the school environment in a way that makes it safer for all kids. But I think in particular to provide those supports incredibly important. There are, as you mentioned, the Trevor Project has done some wonderful work, and they have worked with the with ASCO, School Counselors Association, to pull together a model school policy for suicide prevention, to put some of those policies in place that will hopefully support and prevent prevention among the highest risk youth, and realizing that transgender youth are at highest risk generally in that school population.
And this is John. I would just add that there are some really good resources in addition to the ones that Kathleen mentioned. There's a National Center for Transgender Equality that has a school action center, and they have materials, as well as the organization whose acronym is GLISEN, G-L-S-E-N. They've got model school policies and helpful tools. Folks can maybe Google GLISEN, G-L-S-E-N, or Google NCTE for additional materials.
Great. Thank you. I know we are running very short on time, and we do appreciate our audience's questions, but do want to be cognizant of our speakers' time. So we are going to close out our Q&A session, but we'll share all these questions out with our speakers so we can try to get answers to some of your specific questions. Your feedback is really important to us, so we'd like to ask our audience to take a moment to complete a brief survey, which can be found on the bottom of your screen. We'll also be sharing a recording of the event in case you missed any of the presentations or would like to share it with your colleagues. And you can also find copies of the slides on our website, as well as NIHCM's infographic on youth mental health, as well as some additional resources. We really appreciate our excellent panel of speakers joining us today, and hope that our audience leaves with some ideas to take back to your work and your communities. And thank you all again so much.